Greetings all. My name is Robin Norton. I'm the Principal Director of the George Institute for Global Health. And like many of you, I am currently working from home rather than my usual place of employment, which is the University of Oxford. So thank you all for joining us today, especially during this very challenging time. I'd like to firstly extend thanks to my TGI George Institute for Global Health colleagues who have been involved in organising this: Emma Feeney, Elisa Chaseville Chairs and Annabelle Bertrand, as well as our partners at WHO's Global Coordination Mechanism for NCDs, and indeed to our excellent steering group. This year we commemorate the 25th anniversary of the 1995 Beijing Declaration and Platform for Action. Adopted by 189 countries meeting in China, the declaration and platform remain a hugely significant roadmap for the achievement of gender equality. Among many other actions, it called for data to be collected, analysed and disaggregated by sex, age and other demographic criteria, as well as socioeconomic variables. Today's webinar will look at why this is still such an urgent issue and discuss strategies to accelerate progress. The webinar is intended to be interactive, so please post questions in the question box. And if you have a smartphone, please also participate in Mentimeter by entering the details currently displayed on the PowerPoint slide. It is my pleasure, though, now to introduce our moderator, Albert Motivans. Albert leads data and research for Equal Measures 2030, a civil society and private sector-led data and advocacy initiative. He leads efforts to develop innovative approaches for analysing and visualising development data and for strengthening the technical capacity of national stakeholders to monitor progress and improve policies and development outcomes, while ensuring that data insights are accessible and understandable to all. He has worked in social and economic statistics and development for more than 20 years, including with the UNESCO Institute for Statistics, UNICEF Office for Research, and the US Census Bureau. He has published widely on measurement and policies in education, gender equality, and child welfare. Welcome, Albert, and over to you.
Dr. Norton, and welcome everyone to this excellent opportunity to connect despite the constraints we face today. So I'm going to moderate the panel, and I want to just say a few words in advance. You saw the reference to the Mentimeter. You can also use your laptop to access the Mentimeter. I put in my answer for the first question. If you haven't yet, you still have an opportunity, and we'll be returning to sets of other questions as we go through the panel. We have an hour and a half, 90 minutes. We have 3 excellent presentations addressing different perspectives on the issues that that were just presented around looking at the sex disaggregated data and gender sensitive data in the realm of non-communicable diseases. Each speaker will have roughly 15 minutes to present. I'll be keeping time and try to keep our speakers to time so that we have sufficient time for discussion. We'll hold questions to the end after all 3 presenters. And in the meantime, you can still submit your questions, and in fact, you're encouraged to submit your questions using the chat box on your screen. So if a question comes up during a presentation, please go ahead and send it right away. We'll be compiling the questions and addressing them at the end with the authors. So please do post your questions then, and hope we have sufficient time for Q&A. And as you can see, we have quite illustrious presenters here representing different regions, different countries, and let's dive right in. So I wanted to say just a few words in introduction around the work of Equal Measures quickly, and then also about just some of the starting points in terms of defining terms and defining concepts that I think are helpful for these presentations. So the Equal Measures 2030 partnership involves, as you can see, a range of partners. I think what's important to note here is not only the international NGOs around data and health, but also are linked to feminist networks at the regional level. So Femnet in Africa, Arrow in Asia, and CLADM in Latin America and the Caribbean. We also have national partners in 7 countries that we work directly with. Next slide. So what we try to do is we're trying to connect data and evidence with advocacy and action. And we do this in a very broad way. Our partners are deciding at the national level which issues that they want to take forward. It's very much demand driven. And then we help support and facilitate capacity building and the funding actually that's helpful for these grassroots organizations to deliver on their advocacy and to change policies in a wide range of issues, from health and education to land ownership to women's leadership. Next slide, please. So you can find some of our work. Oh, it's cut off on the slide, at least on my screen. It's data.e2030.org, and you can find a number of the data that we present. We have a SDG Gender Index, which looks across 51 issues, including almost all of the Sustainable Development Goals, and we have 51 indicators, including some common risk factors for non-communicable diseases, and you can interact with the data there. So let's turn to the theme of the panel, and I think it's important to look at the big picture too. I think it's important to keep in mind where the health sector is relative to where other sectors are as well. And I think what we've seen in terms of recent mappings of sex-disaggregated and gender-sensitive SDG data is that there is a lot of work that really needs to be done. When we look at the gender-related SDG targets, there's 252 indicators. Only 21% of the data needed to monitor the gender-related targets are currently available or reported. So that means 4 out of 5 issues, indicators related to girls and women don't have the data to inform in relation to progress. And then we see from UN Women that it's not only about the data gaps, it's also about the quality of data that does exist. And we see real problems in timeliness and coverage. So of those data that are available, they're not very timely. And so only one out of 4 indicators is from the last decade. So from 2010 or later. So in truth, many of them are fairly recent, but also there are older data for a number of countries. And the problem with looking at data over time and trends, whether things are improving or falling backwards, is that very few of these indicators are available for more than 2 points in time. And that's something about the data that we have, the data that we still need, but it's important to highlight, I think, kind of a growing wave of thought, and I think which some of the presenters today will be addressing, is around the observations like those of Caroline Criado Perez, that the data gaps result from not considering how women's needs are different, and by not engaging women as part of the design stage. And oftentimes we're looking at the end stage, the end product. Are the data disaggregated? Could they be disaggregated? Are the data available? When in fact, we need to go back even further to looking at how these data collections are designed and whether they're taking into account the specific needs of girls and women. Next slide. So when we talk about sex disaggregated and gender sensitive, just to be clear about the concepts, when we talk about data disaggregated by sex, we're referring to the biological and physiological concept of sex, and it's data that are cross-classified by sex. So it's an effort to present information separately for men and women and boys and girls. And we don't always see that's the case. Oftentimes it's not disaggregated when it should be. And that's something that's I think a really key to monitoring whether we're going to make any progress on the goals. And then gender sensitive data is taking that idea of that I just mentioned about, kind of looking at the design. So gender, then we're talking about a social construct, about norms and roles. But what we talk about gender sensitive data, it's not only disaggregation, it's about approaches that intentionally consider gender related needs, perspectives and experiences in design, collection, interpretation, and use all across the data value added chain so that they better reflect girls and women's realities and that they help us to understand the developmental differences between girls and boys and women and men. So I hope that's helpful as a starting point. And let's go on now to the first panel, or the first panelist. And I'll start with an introduction. So in this first presentation on women and non-communicable diseases in the Caribbean, we have Dr. Kim Quimby. She's a senior lecturer in immunology at the George Lane Chronic Disease Research Center at the University of West Indies. She's a clinician scientist whose previous work focused on the inflammatory response in sickle cell disease. And she's recently transitioned to a translational science focus and is currently the PI, the principal investigator of the Barbados Diabetes Remission Study. She'll be presenting together with her colleague, Dr. Natasha Sobers. And Dr. Sobers is a lecturer in public health and epidemiology at the University of West Indies, the Cave Hill campus, and she's the lead researcher of the Barbados National Registry for Non-Communicable Diseases, which focuses on heart attacks, stroke, and cancer. Natasha is a UWI medical graduate, a US Fulbright scholar, and a Bernard Lowen Scholar in Cardiovascular Health at the Harvard T.H. Chan School of Public Health. Natasha has been a medical practitioner in Barbados for over 15 years. So I'll turn it over to you and start the clock. Please begin. Thanks.
Thank you very much. So Kim and I are really pleased for the opportunity to discuss some of this information from the Caribbean on sex disaggregated data relating to cardiovascular risk factors and diabetes. So next slide. I will talk about some of our findings regarding risk in women and provide background for the work which Kim is leading. And then Kim is going to continue by talking about some of her work. So working with a research group known as the United States Caribbean Alliance for Health Disparity Researchers, we examined some of the state of the literature as it regards the association between a selection of health inequities and diabetes. So slide this. As you can see, we looked at education, employment, ethnicity, but by far the most common health inequity that was looked at was gender, where there were 267 studies looking at gender and some of the diabetes and its risk factors. So
I'm sorry, Dr. Quimby. Sorry, could you just maybe speak a little bit closer to the microphone? You're coming through, but maybe just a little bit better would be great. Thank you.
So can you hear me better now?
Much better, thank you.
Okay, yeah. Okay, so what I was saying before is that we worked with a research group, the Caribbean Alliance. So it was, we looked especially at all the Caribbean data, and we looked at several health inequities. And what we found, of course, that one of the most common things that was reported was between gender and diabetes and its risk factors. I'm going to focus in just looking at this background on what we found as it regards to diabetes, as it regards to obesity, and as it regards to physical inactivity, because that has significant repercussions for the work that Kim is now leading in terms of implementation. So I'm going to, like I said, focus on those three things, but if you want further details, you can look for these two publications where we've explored many of the associations between gender and some of the risk factors. So the first was published in PLOS One in April 2015, and the second one, an updated systematic review where we included published and unpublished data, was published in PAHO Journal in 2018. Next slide. Right, so obesity and gender, what did we find? So if you look at this forest plot, you will find that on the left, we've listed all of the studies that we looked at from throughout the Caribbean, from Aruba, Trinidad to Trinidad and Tobago, Suriname, etc. And you will notice that consistently women had a higher percentage of obesity, higher prevalence of obesity within the population, with the exception of one country, and that is Aruba, which is first. So from throughout Barbados to all the other countries. So, and these studies range from 2006 all the way to 2015 in terms of the publications. In summary, you will notice from the forest plot that if you look at the figure at the bottom, that what we found in summary, when we put all the studies together, that women are 2.1 times more likely to be obese than men, or we could say generally that they're twice as likely to be obese than men. Next slide. Right, so we also looked, so physical inactivity and gender. We're looking at physical inactivity and gender. So the slide before this. Right, so physical inactivity and gender. We looked at obesity first, now physical inactivity and gender. When we looked at this, we found something similar, that women were far more likely to be physically inactive than men. This was consistent for all of the studies, including Aruba. So we looked at Aruba, Suriname, Bermuda, all the way to Trinidad and Tobago. We found, as a summary, when we put all these results together, that women were 2.18 times more likely to be inactive than men. And so finally, just giving you some of the results from diabetes prevalence and gender. So then, thank you. So diabetes prevalence and gender. And notice that for this one, we're taking only the objective measurements. So when we looked at this, for most of the countries, almost all the countries except for 2, women were more likely to have diabetes than men. So if you look through from Jamaica, the studies from Aruba, Belize, Bermuda, the men and women have a similar risk of diabetes. And in Puerto Rico, they found that men had a much higher risk of diabetes. All the other studies essentially found that women had a higher risk. So overall, if you look at the summary result at the bottom, the summary diamond at the bottom, what you will find is that women were 1.48 times, or just rounding off, we can say women were 1.5 times more likely to have diabetes than men. And so based on this, Dr. Quimby will now talk about some of the interventions that we're looking at to try to tackle this higher prevalence of obesity, the higher prevalence of physical inactivity, and the higher prevalence of diabetes in women. So thank you, Natasha. So if you just go on to the next slide, please. Thanks. So it's against that background that we looked at the Beijing 25 Declaration. And one of the objectives stated was to increase women's access throughout the life cycle to appropriate, affordable, and quality healthcare and information and related services. Next slide, please. So the action for the, no, thank you. So the action was to design and implement, in cooperation with women and community-based organizations, gender-sensitive health programs, including decentralized health services. Next slide. So the Barbados Diabetes Remission Study, Part 2, this was based on the work done by Roy Taylor out of Newcastle, but this was our community-based intervention of that study. So basically participants were persons who had type 2 diabetes for less than 6 years or pre-diabetes, and they were placed on a low-calorie diet, 840 calories per day for 12 weeks, and that caused weight loss and thereby affected type 2 diabetes or pre-diabetes reversal. Next slide. So as I said, this was a community-based intervention. So in choosing our community sites, we had 2 questions. Where are the women? And is this a place where quality healthcare can be delivered? Next slide. So in choosing our community sites, we first looked at faith-based organizations. And we chose the faith-based organizations because there was a high density of churches on the island, more than 300 in our 166 square miles. And these faith-based organizations were already integrated into the surrounding communities because they function as community disaster shelters during the island's hurricane months. The churches were purportedly sampled because we wanted to ensure there was a medical doctor that's a part of the congregation. And when we spoke to the leadership of the churches, they informed us that there was an average membership of more than 70% women within the churches. So that answered our questions about where we can find the women. Then we were on to our second question: is this a place where you can get quality health care? Now, we already ensured that there was a health practitioner who was a part of the congregation. But in order to run this study, the health practitioner would need a team to work with. And so we looked at recruiting community health advocates. Forward, please. So when we went to the churches, we went during one of the major church services and we asked for volunteers to become community health advocates. So basically, any adult member of the faith-based organization could volunteer to be a community health advocate. So what did they have to do? We offered a 10-week training program, which was mandatory. And during this time, volunteers were taught to do clinical measures associated with the diabetes remission program. So they were taught to do blood pressures using automated machines, blood sugars using glucometers, weights, heights, and waist and hip circumferences. They were also taught to do data entry using the Red Cat online database so as to get around the paper-based system. Following their 10-week training program, they had to take and pass a clinical examination. So this was in an OSCE format, and the exam was monitored by a clinical practitioner external to the study. Once they were certified as community health advocates, they were then expected to perform the above clinical measures for participants according to the interview schedule. And I'll let you know what this interview schedule is in the next slide. So once we had the faith-based organizations, our community sites, and we had our community health advocates in place, we then looked towards our participants. So participants must be adults 20 to 70 years old, type 2 diabetes for less than 6 years, or pre-diabetes, and this was defined by the ADA criteria. They had to be overweight, so a BMI of more than 27, and we started with regular attendees of one of the 3 FBOs, although we have now branched out to include additional persons within the communities. So what was expected from the participants? Next slide. The intervention was divided into 3 phases. The first phase was the 12-week low-calorie dietary phase. The daily allowance was 840 calories, and this comprised of 4 shakes and 4 portions of non-starchy vegetables per day. On the first day of the intervention, participants were advised to stop all of their diabetes medication, but they would continue all of their other medication. They then made weekly visits to the faith-based organization to be seen by their community health advocate for the above clinical measures that we mentioned in the previous slide. And community health advocates also monitor their pressure in case the hypertension medication needs to be adjusted, as we saw a reduction in blood pressure throughout the 12 weeks. At the end of the 12 weeks, participants transitioned back to a healthy, balanced, reduced calorie diet. So additional foods were added in under the guidance of their nutritionist. And during this time, they were seen at the faith-based organization monthly by their community health advocate. The 6 to 12-month period was a period of relative independence. We still kept in contact face-to-face during church services and also by WhatsApp, but there were no formal measurements being done during the 6 to the 12-month period. But then they came a year for the final visit by the community health advocate. So what did we find? So first, looking at our community health advocates, 40 persons volunteered across the 3 churches to be trained. 88% of those who volunteered were women. 27 of those 40 completed the training program, and 85% were women. And here the picture you can see on the left is one of the teams at one of the faith-based organizations. Next slide, please. So now looking at participants, 156 persons were screened, and 31 persons were found to be eligible and were enrolled. Of those 31%, 31 persons, 90% were women. 11 had type 2 diabetes and 20 were pre-diabetic. Of the 11 who had type 2 diabetes, 10 of them were women. 3 of those 11 were diagnosed only during screening for that study, and all 3 of them were female. Of the 20 who had 2 pre-diabetes, previous slide please, 18 were females, and of that 20, 16 were diagnosed during screening for the study, and 15 of those were women. Next slide please. So if we now look at the change in weight and glucose over that 12-week period, so on the left axis is looking at weight in kilograms, and the right axis is the fasting blood glucose in millimoles per liter. Advance the slide, please. So the weight reduced from 95 kilograms to about 87 kilograms over the 12-week period. That's a weight loss of about 8 kilograms. Next slide. The fasted blood glucose followed an almost identical pattern, reducing from about 6.5 to about 6.2 millimoles over the 12-week period. Advance. We then look at the fasted blood glucose in those who are diabetic or those who are pre-diabetic. So the yellow line is for those who have type 2 diabetes, the gray line for those who have pre-diabetes, and we would expect that the gray line would have the higher average as those the persons who had diabetes. But we can see they followed a similar pattern with a kind of steady reduction over the 12-week period. When we looked at the A1C, so this is a measure of diabetes over the 3-month period, it was only done at 2 time points, either pre-intervention or at the 12-week intervention period. So the blue line is for the total A1C, and we see a reduction of about 0.3%. The red line are those who were pre-diabetic, and that remained about stable over the 12-week period. But for those who had type 2 diabetes, that's the gray line at the top, they had a loss of a 1% A1C over that 12-week period. Next slide, please. So if we just look at gender-specific outcomes, so we pull the women out and look at their weight and glucose during that time. So the blue line, that's the total weight loss for men and women. And then the red line below is when we just look at the women-specific data. And we can see that when we started, women started about 2 kilograms lighter, but the progression, the weight loss was at a rate almost similar to the overall population. In the middle graph, looking at fasting blood glucose, the top 2, the gray and the yellow, those are for the persons who are diabetes, and the blue and the red are for those who have pre-diabetes. The gray line is the total, and the yellow are just the females. So females started at the same 6.6 as the overall population, but they did just slightly better than the total population. And for the persons who have pre-diabetes, that's the red and the green. Again, the females started at a slightly lower rate, but we ended up at the same point as overall population. So now looking at the A1C, it's a similar pattern, with the persons who have pre-diabetes being at the top, and diabetes at the top, and the blue and red pre-diabetes at the bottom, and we see the loss of A1C's percentage over time. So when we look at that in context, we're looking at actually who had pre-diabetes remission or who had type 2 diabetes remission, and this is looking specifically at the women. So pre-diabetes remission was defined as a fasting blood glucose of less than 5.6 at the end of the intervention. So of the 13 women for who we had pre and post rates, 46% of them were able to achieve pre-diabetes remission based on fasting blood glucose. If we look at the A1C of less than 5.7%, 20% of women were able to achieve pre-diabetes remission at the end of the intervention. If we're looking at diabetes remission now, that is a fasting blood glucose of less than 7 at the end of the intervention while being off of their medication. Approximately 90% of the women were able to achieve diabetes remission at the end of the 12 weeks. And if we look at the use A1C of less than 6.5, 67% of the women were able to achieve diabetes remission at the end of the 12 weeks. Next slide. So in conclusion, we have seen that female gender is a social determinant for diabetes in the Caribbean. we see that obesity, which is a risk factor for diabetes, is more prevalent in women in the Caribbean. We've noted that women constitute the majority of the membership in faith-based organizations in Barbados, and hence having a community intervention in faith-based organizations is a good place to find the women. We see that the Barbados Diabetes Remission Study, which is a faith-based organization-based intervention that induces weight loss and thereby diabetes remission. And we have shown that the BDRS2 protocol is both a feasible and clinically effective means of reversing diabetes. On our final slide, we would just like to acknowledge the University of the West Indies and the George Allen Chronic Disease Research Center where we work, and the Massey Foundation who gave us the funds to do this study. So thank you for listening.
Great. Well, thank you very much, Drs. Quimby and Sobers, for an excellent presentation. We are starting to get questions on the presentation. You can use either the Q&A box or the chat box to send your questions, and we'll come back to those at the end of the webinar. Also, before we come to the discussion period, we'll also be reviewing the Mentimeter results. So we had one question at the outset, and now here's the next question. So either on your laptop or your smartphone, go to www.menti.com, use the code, and then answer the question, and we'll tabulate the results from all of the participants on the call, on the webinar, and get a better understanding of some of these issues. So now we'll turn to the next presenters, and the next presenters will be looking at approaches, challenges, and facilitation to collecting sex and gender disaggregated NCD data, in particular looking at the STEPS risk factor survey in Eastern Europe. This will be presented by Dr. Isabel Yordi Aguirre, the WHO Regional Office for Europe, with the participation from her colleagues in the discussion, Dr. Ivo Rakovac and Brett Craig. So just to say a few words about Dr. Aguirre. She is the program manager of the Gender and Human Rights Program in the WHO Regional Office for Europe, based in Copenhagen. This program is responsible for mainstreaming gender and providing technical assistance to the 53 member states of the WHO European region. She holds a master's in political science and an MBA. She has more than 20 years of international experience with the United Nations, and she combines experience on gender, strategic planning, and health. And again, she's joined by her teammates, Dr. Ivo Rakovac and Dr. Brett Craig. So please, Madame Aguirre.
Thank you. Can you hear me well?
Yes, very good. Thank you.
Okay. Thank you very much. Thanks for the introduction. I will be making the presentation on behalf of Ivo Rakovac, who is the program manager for the monitoring of the NCDs in our office, and Brett Craig, who is the consultant who helped us do the work that I'm going to present. So next slides. I just want to say that to put a policy framework of the work we are doing, as I said, the European region has 53 member states, and we have a regional committee which is formed by all the ministers of health that meet every year. And in 2016 and 2018, they endorsed two key policy frameworks for our work, which is the women's health and the men's health strategy. So we are implementing these two strategies under a gender framework, and we are implementing them together. And in this regard, we collaborate closely with many of the colleagues, and this has been actually an interdivisional approach. Next slide, please. I forgot to put one key slide that we use on what was the driver of the collaboration and looking at gender into NCDs. And I think it's well known the premature mortality among men in the European region, in the eastern part of the European region, and how this is mostly driven for cardiovascular diseases. So we started this collaboration of using a gender approach to NCDs. That was the driver, but the reality is that NCDs are also the main burden of disease for women. So it's for both men and women. we do have a strong link between gender and issues like income, education, geographical place of living, and also intersectionalities with other forms of inequality. But we also have a strong impact on gender, the way they impact the way men and women use services and the responses they receive. And also we wanted to look at what is the impact of gender inequalities on the access to resources. So I want to say that both our strategies were supported by 2 regional reports, one on women's health and one on men's health. And these reports were gathering the information we have across the countries on these areas. So next slide, please. So one of the things that we decided to do is looking at the untapped potential we had in the region with survey data. So we have several key surveys in our region, and I could see also that Dr. Quimby presented the STEPS data from Barbados. But we have the STEPS, which is the WISE approach to surveillance, but we also have the WHO European Childhood Obesity Survey Initiative, and we have the Global Adult Tobacco Survey and the Global Youth Tobacco Survey and the health behavior in school-age children. So we started looking at these surveys, at the questionnaires, and at the data they were collecting, and how in some cases they had a vast amount of sex-disaggregated data that was not used for a gender analysis. So next slide, please. So we started with the STEPS also because it was the one that was closer related to the premature mortality. And the reason why we have the STEPS, for those that are not familiar, is because it's a key tool on gathering information on NCD risk factors. It collects standardized high-quality data and provides reference methodology for WHO on how to do NCD surveillance. It's also a very good entry point for countries to get started on this surveillance, and at the same time, the process of having the survey builds capacity in countries. So we use it as an integrated approach and with a relatively low cost. This is the framework of the STEPS survey. So we have the 3 steps, the modules and the sample. And my colleague Rakovac will be the person to answer any specific questions about what it is, the methodology, the framework, and the type of process that we have in countries. So next slide, please. So what we did is that we started by 6 countries that had either done recently or were embarking on doing the STEP surveys in our region, in the eastern part of the region. And we look at the differences on health outcomes, particularly mortality, but also morbidity. What were the differences in risk factors, behavioral and biological, and what are the difference in access and response for the health services? And we look at this data by sex and age, but also we made an effort on seeing what were the cross links with education, rural, urban, marital status, and employment status, because we realized that when countries that had this vast information were not always looking at what the data had. So some of the findings we had are not new, but it is interesting to see. They're not new for the gender people, but in many cases they were new for the NCDs people. And I think that this was one of the main objectives also of this initiative, to look at how could we cross-cut with between the 2 groups. So a well-known thing, one of the issues that we found, the first one is that for when we look at behavioral risk factors in most of the countries, in all the countries, I mean, we did have higher behavioral risk factors for men than for women, with the exception in some cases of physical activity. And when we look at the biological risk factors, what we had, it's actually a higher number for women than for men. If you look at the graph there, you have the gaps in some cases. They have gaps in behavioral and in biological. Next slide, please. So what we also did, and I think that this may be something that we use very much also when we look at the differences between behavior and biological, and it is when we look at premature mortality and we have the interval 30 and 69, we are masking the big biological differences that happen in women after menopause, so usually after 50. So we see that the difference in risk factor trajectories over the life course, and when we have these groupings, that makes the picture much more interesting and the nuances are stronger. So we see difference in risk factors in trajectories over the life course. So more men in the younger age groups have multiple risk factors, but we see the accumulation of risk factors in women is more rapid and it starts from middle age, particularly after menopause. The mortality rates for men in the groups 45-59 and 60-69 age groups are 2 to 3 times the rates of women in most countries. And we also can't anticipate that maybe higher levels of premature mortality could contribute to lower prevalence of risk factors among males in older age. Next slide, please. So another issue, one of the findings, and I'm just highlighting some of the issues we picked up, is that the higher percentages of men that have not been measured for biological risk factors, and we have a higher percentage of women that are being given lifestyle advice on most behavioral risk factors. So with the exception of tobacco, we see that women get more often more behavioral advice, even though they have less prevalence of risk factors. On the left figures, you have the percentages of men and women who have not been measured for risk factor by a healthcare provider, and the percentages of men and women who have received lifestyle advice by a health provider. So we see the higher number, the blue dots of women, receiving lifestyle advice, except for the tobacco, which is on the left-hand side. And in the other ones, we see that that's what has been tend to be called the missing men, particularly for the blood pressure on the left ones, with men not having the blood pressure measured by the health services. If we go to the next slide, please. So what we have also, another issue, is that the prevalence of both the behavioral and the biological risk factor varies in subgroups of men and women, and these subgroups are not equal in the relation to the risk factors. So we didn't want to look at men and women in general, and the STEPS data books provides the opportunity of making the differences and the links with some stratifiers like education and income and place of residence. So if we look at, for instance, the geographical location and what is the prevalence of biological risk factors in this figure, we can see, no, the previous one, yeah, next one, right there, yeah. So if we look at the prevalence of biological risk factors for men and women, we see that the behavioral risk factors are high among men in urban areas, but this is the case for women in rural areas. So the geographical situation does not have the same impact in men and women. We go to the next one, please. In this case, the geographical location seems to have a bigger impact of men than on women. So if we look at the percentage of men and women that are not measured for risk factors by geographical location, we can see that there is a difference between men, whether they live in a rural or an urban area, but this does not count as an important determinant for women. They are missing at the same rates in rural and in urban areas. We go to the next. And just to mention that these are some of the country examples, and the reason why I'm not mentioning the countries because this work has not been published yet, and we are in the last phases of reviewing it. But just to say that the 6 countries that we did have the first assessment were Armenia, Belarus, Georgia, Kyrgyzstan, the Republic of Moldova, and Turkey. So in this example, what we see is that while women in the lower education levels tend to have higher prevalence of biological risk factor, is it men in the higher education levels that have the higher prevalence. So education has a different impact on men and women. And we also see that the prevalence and the tobacco and alcohol use is not being influenced by education in the same way. And I think that's also important when we look at the subgroups and the different risk factors, also this differential impact of men and women. So we see that, for instance, men and women with lower education have a higher tobacco use, but men and women from higher education groups have a higher prevalence in alcohol use. So these are some of the cross sections we did. When we look, for instance, at the percentage of men and women not measured by risk factors by income level, we see that income level is also more relevant for differences between men and women on measuring blood pressure, but it doesn't make a big difference in the other risk factors like blood glucose and cholesterol. If we go to the next one, and these are the challenges that what are we going to do with this? I mean, first of all, what we find also when we have this survey data is that we do need sometimes a bigger sample to make the disaggregation meaningful. In some of the cases, we were having very few numbers of data that we could extrapolate the findings. So when we look at sex, age, and other demographic variables, then the sample needs to be, in some cases, a little bigger to allow this meaningful disaggregation. But if we do not have this disaggregation, we are missing the identifying the groups that are higher risk. What we also see for the people responsible for making these analyses at the country level is that here we are presenting the differences. However, we do not have the reasons behind these differences. But even to make this cross analysis is considered an extra one. However, and there is no doubt that it requires extra work because you have to make extra tabulations and cross references. However, what we saw, and we've had 2 meetings with the national focal points that are responsible for doing and collecting the data and doing the analysis of the STEP survey, is that this was really an eye-opener. I mean, it presented nuances that in some cases they were considering revising their policies because they were not targeting the right groups. So even of the extra work and the extra analysis, we did have an impact on the responsible people collecting this data. We are also very conscious that the presentation of and the correlations we can do requires further quantitative and qualitative methods that allow us to understand the differences or the non-differences. And particularly, which is not that clear from the data, the impact of gender inequalities on access to services. We do see some of the data that shows the impact of gender stereotypes in exposure to risk and access and the response from services. And in some cases, when we were combining, or countries said that they had a big difference, for instance, on the reporting of women smoking when they were doing the nicotine test, that gap that shows that more women are smoking that they are reporting in survey data shows also areas where we do need to have an intervention in terms of challenging those gender stereotypes that make it more stigmatizing for women to smoke. Therefore, they don't come out to the services and therefore they don't receive the appropriate responses. But what we have seen, and as I said, and I thank Alisa and the others for asking us to make this presentation, even though we have not finished it, is that we in these meetings that we had with the countries, it was also very powerful to present what next? What do you do with this data? A little bit what our colleagues from Barbados were presenting on the diabetes one, right? How do you identify the groups more at risk? How do you identify the differences by risk factor? How do you identify the biases from the surveys? For instance, the fact that despite having lower risk factors, is it women that get the lifestyle advice from the healthcare providers? It may be because it is women that go to the services, but there is a need to revise what it is the advice that we are giving. And I think this is the last slide. Yes, thank you very much. And of course, my colleagues Ivo and Brett are ready also to jump in and answer any of the questions you may have. Thank you very much.
Okay, thank you very much, Ms. Aguirre. I think that was really a fascinating results that you presented. And maybe if you could just now quickly tell us when the report might be coming out.
Yes, we are actually preparing right now the 6 country profiles. We are hoping to have them ready within this month. Of course, like everyone else, we have been drawn into other priorities. And actually, I also want to make a call for the sex disaggregation of the data on COVID-19. We saw at the beginning of the reporting, at least in WHO, we were getting sex disaggregated data, then countries stopped doing that. I think that they are still collecting them, but they are not reporting them to us. So, but despite COVID-19, we want to have the 6 country profiles ready by mid-April, and we are preparing a synthesis report of the findings also that will be ready more or less at the same time of the 6 countries. But also to say that this is an ongoing process. So we already have 2 more country requests, Uzbekistan and Ukraine, that want to do the country reports. And also to something that I didn't have any figures, but it is also fascinating and an excellent tool to look at trends for those countries that have done the steps every 4 years and can already look at changes in the risk factors.
Okay, great. Thank you again. And I see some questions are popping up already in the chat box and the Q&A box. So please, if you have questions for the discussion later, then please feel encouraged to post them. And now I'm going to also encourage you to respond to what now are 3 questions in the menti.com. Again, if you haven't been there yet, just go ahead with on your laptop, on your smartphone, go to the website that's listed in the slide, insert the code, and then answer the questions. And again, we'll come back to then the results after the next presentation. So I want to then introduce then our 3rd and final presenter. And as you might have noticed, we're kind of moving upwards. We started with a case study. We looked at some interesting regional results and comparisons. And now we're going to pull back to looking at larger questions about rationale and strategies for conducting the sex and gender disaggregated data analysis. The presenter will be Dr. Sanne Peters, who is a research fellow in epidemiology at the George Institute for Global Health at the University of Oxford. She obtained her PhD in epidemiology from Utrecht University and has worked as a postdoctoral research fellow at Utrecht and at the University of Cambridge. Her research is primarily focused on the determination and identification of major and modifiable risk factors for chronic disease and how these associations may differ between women and men. So I'll turn now to Dr. Peters and the last presentation, please.
Thanks, Albert, for introducing me. Can you hear me?
Perfectly.
Okay, great. Yeah, thanks. It's indeed an honor to be talking to you today about this topic, and it's indeed also nice to follow up upon the excellent presentations by the previous speakers. So I'm indeed going to take a step back, and I'm going to talk about why we actually want to look at sex and gender differences. I mean, a lot of this has, of course, has already been covered by the previous speakers. Next slide, please. But the reason for doing this is really that historically most research on non-communicable diseases, but also as we see with, but also health and disease in general, was done in male populations, and this was done initially because women were considered to be a vulnerable population. Women were, you know, we didn't want to be doing research among well, women, because they could be pregnant, and we didn't want to harm the unborn baby, etc. But we now know that that the results from the studies conducted in men do not equally apply to women, and that's why we increasingly start to do sex and gender disaggregated research. Next slide, please. So this has been quite a topical topic, and I'm now just going to flick through a couple of recent articles in The Guardian. Next slide, please. By a big news show in the US, by John Oliver, who did an excellent video on the importance of sex and gender analysis in health research. Next slide, please. Again, another book on the topic. Next, please. Caroline Criado Perez, who arguably is one of the main champions, of course, also about the importance of doing sex and gender analysis, and she's built an excellent case around the data bias that's present in the world today, because well, lots of the things we've developed, not only in health but also more broadly, are actually designed for men. And then finally, the British Heart Foundation earlier last year presented reports about bias and biology in coronary heart disease, and how the gender gap in heart disease is costing women's lives. So, you know, this is an issue that's gone beyond academia alone, and has clearly reached the broader audience. So next slide, please. So then coming to the rationale of why we're doing all this, well, it's clear that we can increase our knowledge about disease and improve health outcomes, both for women and for men, by doing these sex disaggregated analysis. And I'm saying sex, but clearly gender analysis also apply. But it's still commonly the case that the data that are available to us do not really allow for gender analysis, because we do not really know about all the gender determinants. So that's why we still often stratify the data by, yeah, the simple dichotomous the categorization between being a woman or being a man. But clearly there's scope to go beyond that, and to also consider gender. Next slide, please. So one issue that we've come across is that there aren't enough women in studies. And this slide shows, provides an overview of the participation of women in clinical trials supporting FDA approval of cardiovascular drugs. And what you see here is in the y-axis, there's different diseases, and on the x-axis you see the participation to prevalence ratio. So in other words, what the authors of this work did, they looked at whether the participation in trials was similar to the actual prevalence of these cardiovascular conditions in the population. A PPR of 1 indicates that the prevalence and the participation ratio were equal. If it's lower than 1, it indicates that women were less likely than men to be included when adjusted for differences in prevalence. And what you see is that for many conditions, including acute coronary syndrome and heart failure, for example, women were way less likely to be included in the studies, despite, well, for some conditions, a higher prevalence of these conditions. Next slide, please. So in addition to the lack of women in studies, there's also still a lack of sex disaggregated analysis. In the next couple of slides, I'm going to talk you through a couple of steps that you may want to consider when looking at sex and gender differences in studies. This is a report written by one of my colleagues at the George Institute, Professor Mark Woodward, who's written an excellent tutorial around how we can actually implement these sex and gender specific analysis. In this specific example, to study sex differences in cardiovascular risk factor associations. But as you can see from the table here, many of the recommendations provided in the table actually also apply to a broader range of sex and gender specific research questions you may want to address. I've added a couple of errors to this slide because those are the recommendations I'm going to read out. It's not to say that the other recommendations aren't important, but I just wanted to flag those up. So I'm just going to read them out. So as a starting point, I think every researcher really should consider whether the research they're going to do is concerned with either sex, which is the biological factor, or gender. And if so, the results should be reported accordingly. So secondly, and this is already similar to what I said before, we really need to provide sex-disaggregated results and reporting research. Not only, I think, on cardiovascular risk factor associations, but really in general when it comes to health questions that are relevant for both women and men. In some cases, a study may be concerned with a single sex, but it may be possible to then use the other sex as a control, and I will show an example of that later. So it may be that a question is only seems relevant for women, but in order to make sure that assumption is true, we may want to use men as a reference in the analysis. Given that women and men have a very different life expectancy, this is recommendation G4, you really want to adjust for age when looking at sex differences. Not only in cardiovascular risk factor associations, but I think more broadly. We want to consider the analysis both on the relative and absolute scales, and we also want to make sure that that once we do meta-analysis, and I'm now jumping towards the other 2 points lower at the slides, we want to make sure that if we do a meta-analysis, we want to check whether studies that are included in the meta-analysis reported on both women and men. And if a study only reported results on women, such study can't be included in the meta-analysis because results from a different study in men will be from a different reference population, and that won't be that won't be very useful in the meta-analysis. Next slide, please. So I've now just listed a couple of examples of areas of medical and health research that would benefit from sex-disaggregated analysis. So a couple of examples include studies into sex differences in disease occurrence and survival. So this is about whether women and men are equally likely to get, for example, diabetes, as was the topic presented by the first speaker, and whether there are sex differences in survival. You can also think about sex differences in disease presentation, so whether symptoms of a particular condition are different. I'm going to give an example of that as well. There may be sex differences in risk awareness, health behavior. The previous speaker spoke about that, as well as the first speaker. Risk factor associations, I'm going to come to that. Then, of course, if we find differences, we also want to know what underpins those differences. So that's why sex differences and disease mechanisms may be another area of potential interest. Then, of course, there may also be differences in treatment and care provided. And finally, one may want to study sex differences in the effectiveness and safety of intervention. So again, this is not an exhaustive list, but these are a couple of things you may want to think about. In the next couple of slides, I'm just going to go through a couple of examples of studies that me and my colleagues have done in the past that addressed particular aspects of sex differences. So as a starting point, one thing we may want to look at is indeed sex differences in health behavior, and it is also shown by the previous speaker that there are indeed huge differences between women and men when it comes to smoking behavior. This is data from the UK Biobank, where we found that over time, where we saw that in different birth cohorts of participants included in the UK Biobank, women were less likely to smoke than men. The differences decreased over time, but overall women are way less likely to smoke as compared with men. And the differences are even larger in populations in Asia, for example, where hardly any women smokes, but where almost 60% of all men smoke. So these are things you really need to consider when designing health interventions. Next slide, please. So this is an example of sex differences in symptoms for disease, so the disease manifestation. The results presented on this slide result from a meta-analysis where we put together all data available on sex differences in heart disease symptoms. So there's a lot of talk in the literature and also in the general media about symptoms for heart disease that are typical or atypical, and women are often considered to have atypical heart disease symptoms. And that's partially true, and it was also confirmed in this study, because we indeed saw that there are some symptoms such as pain between the shoulder blades and neck pain and palpitations that are more common in women as compared with men. And chest pain is indeed less common in women as compared with men. But overall, and that's something not shown on this slide, but that's presented in the paper. Overall, women and men actually show a lot of similarities in heart disease symptoms as well. So that's important to bear in mind as well. What I wanted to add to here as well is that all the studies included in this meta-analysis provided data on women and men. So what we did is that we compared women and men within the same study and then pulled the results across studies. And the reason I say that is because, and that's coming back to the point I made earlier, is that if we compare men from one study to women from another study, and the men from the one study were 50 years of age, and the women from the other study were 80 years of age, that's not really comparing like with like. So we would like to make equal comparisons within studies and then pull the results across studies. And that's an approach we've taken consistently, and that's an important recommendation, I think, to take home with you. Right. Next, I want to move into sex differences and risk factor disease associations. So this slide presents the results from meta-analysis me and my colleagues have done over the past couple of years, where we looked at the effects of very common risk factors on the risk of both heart disease and stroke in women as compared with men. So in the two columns, you see that high blood pressure, smoking, and both type 1 and type 2 diabetes are associated with a greater risk of getting heart disease and stroke in both sexes. But when you look at the dots and the dots, you actually see that women have for some risk factors have a greater additional risk as compared with men. So for example, for type 2 diabetes, women have a 44% greater excess risk of getting a heart disease as compared with men. And these results were independent of age and other risk factors for heart disease. So there's something about diabetes that seems to put women at a greater excess risk of developing heart disease as compared with men. Next slide, please. So the previous slide was about relative risks. In this study, we also looked at how a difference in relative risks translates in a difference in absolute risks. And the reason for doing that is because women at a given age are at a much lower risk as compared with men to get to get heart disease. So the two bars on the right show the overall risk of myocardial infarction in this UK biobank population. The red bar is for women, the blue bar is for men. And what you see is that in the overall population, women have about 1/3 the risk of getting MI as compared with men. If you then move to the left and, for example, look at the diabetes column, you see that women still have a lower absolute risk of myocardial infarction as compared with men. However, the difference, women do not have only 1/3 the risk, but only half the risk. And this is, and the reason that difference in absolute risk is now smaller than it is for the overall population is because of the greater relative risk of heart disease associated with diabetes in women as compared with men. So what we often see in the literature is that the results from studies about risk factor associations are actually interpreted as studies about about sex differences and risk factors in rates, and that's not the case. So we really need to make sure that we're using absolute risks and relative risks appropriately, and ideally present sex differences both on the absolute and on the relative scale. Right, next slide, please. Couple of more slides. This is another study where we look at sex differences in medication use. What we did, we saw that women are over time less likely than men to receive the guideline recommended dose of statins among all people who are using statins. Next slide, please. So this is so the left-hand slide shows the results on the absolute scale. The right-hand panel shows the differences on the relative scale. So overall, women were just under 10% less likely to receive the guideline recommended statins than men. Next, please. Finally, there are differences in medication use between the sexes. This study published in The Lancet last year shows that men with heart failure achieve their highest benefits of heart failure medications at a much wider range of doses as compared with women. Next slide, please. Because for women, the optimal dose ranges between 50 and 65%, if you like, whereas for men it approximately ranges between 40 and 60%. So that actually raises the question as to whether the current guideline recommendations are correct, but or whether they should be separated by sex as well, which is currently not done. And that's also in part because the trials at present do not allow for solid conclusions about potentially sex-specific doses. Next slide, please.
Sorry, Dr. Peters, so it'll be important to wrap up soon.
Yeah, next slide, please. Next. So I finally wanted to also refer to the SAGE guidelines that also talk about the importance of sex and gender equity in research and provide recommendations about how to do that. Next slide, please. Next slide, please. All right, so I just wanted to come to my conclusions then. There are important differences between the sexes in many areas of disease, not only in heart disease and diabetes, but also across the board. We really need to do sex-specific analysis in order to explore these differences and to improve both women's and men's health. In order to do that, we need to make sure that there are sufficient women in studies. And we, like I mentioned, we need to take a sex-disaggregated approach to collecting and analyzing data. Thank you.
Great, thank you very much, Dr. Peters. I think that was great, strengthening the rationale for the idea behind the entire webinar. So let's, again, we'll have questions for Dr. Peters and others shortly, but we'll turn first to Alyssa Chase-Vilches of the George Institute to present the results of the Mentimeter survey.
Thank you so much. I'm just going to share my screen quickly. Anna, would you mind stopping the screen share, please? Thank you. Great. So I'm just going to go quickly through the Mentimeter results, and thanks everybody who participated in using Mentimeter. So the first question asked about your experience of working with health data in any forms and how often you find that it is disaggregated by sex. And the results we found here are actually encouraging. Most people do frequently encounter data sources that are disaggregated. However, we do want to work together towards moving it more towards always or usually, so that we're consistently able to design interventions that are informed by sex differences. So the next question that we asked was just intended to emphasize again what we've been talking about throughout the whole webinar. Those who answered all of the above to the different choices of where there are sex and gender differences were correct. And again, the idea here is to highlight that we want to be advocating for the design of studies that are able to capture sex and gender differences. And we want to also be advocating for reporting such differences in the research that we publish. So we asked a couple of questions about the barriers to sex and gender disaggregated data collection. We didn't get a lot of responses to the questions towards the end. Admittedly, we were going through the slides, the Mentimeter slides quite quickly, but just wanted to highlight here that for most people, awareness is not an issue. Most people are aware that we should be disaggregating by sex and gender. And we look at it in terms of the availability in secondary data sources to actually do such analyses. We find that we're usually able to disaggregate by sex, but not by gender. And Sanne Peters in her presentation just now highlighted some of the barriers to doing that. And I want to turn it back to Albert now, and I think maybe as a group we can discuss how we might actually be able to start disaggregating our data by gender and not just by biological sex. Thank you.
Okay, great. Thank you, Alyssa. And so let's move on to the discussion questions. And there have been quite, I've been muted. Great, thanks. So let's turn to the discussion now. We have the next 12 minutes for questions. We have had a great number of really interesting questions that have been submitted through the chat form. And the panel, there's some of the questions have been selected for the panel. We won't be able to get to all of them. So I would encourage you to take your question directly to the presenters. And I believe that the recording of the webinar and potentially the PowerPoints or other resources will be made available online as well. So let me start with a question that kind of links to the Mentimeter results that Alyssa just presented for each of the panelists, or for those panelists who are interested in responding. And then I'll have individual questions for each of the panelists as well. So starting with the general questions, what variables can we use, what variables can we use to collect information that tells us about the sociological differences between women and men? That is, like, how to specifically help us conduct gender sensitive as opposed to just sex sensitive analyses. So that's for all of the panelists. And I think you can.
I can answer that one. This is Sanne speaking.
Okay.
Yeah, there have been a couple of initiatives, if you like, to develop a so-called gender score. And what those gender scores generally include is information around topics that generally, well, are gendered, if you like. So that's about income, that's about employment status, that's around activities, I suppose. But they're often household activities and also employment status variables that are included in those such a gender score. In addition, of course, to emotional and behavioral factors. That's my answer.
Okay, thanks. Another panelist?
Yeah, I think.
Go ahead.
Yeah. Hi. No, I think that also one that we are finding useful and difficult is the migration status. and how does it link both, I mean, within the household also for migrants, but also for those that are being left behind. So whether you are in a household with the main breadwinner it's a migrant, or whether you are the migrant of what type of migration. That's another one that we have. We have been looking also for a gender analysis when we are looking at the imbalance of long-term care. Also the living arrangements, whether you live alone or in partnership or within the family, particularly in older age, that makes a difference. That can be very useful for the gender analysis. And I think that may be one also of the issues that may be relevant for the COVID.
Mm-hmm. Good, thank you. Please.
So just to say that I completely agree with Dr. Peters in terms of the variables and thinking about a gender score. I just putting on the hat also thinking about small island developing states or small populations. In terms of gender disaggregation, we would then have to, because there are more genders than there are sexes, we would then have to collect or have larger population-based studies, larger numbers, thinking about sample size. So I think for us that can be a bit of a challenge, and we might have to think about grouping genders and thinking about the way that we measure gender or define gender.
Okay, great, thank you. And just to add from my perspective, I think there's clearly a move away from the binary in almost every field of measurement, and really looking at the gender constructs as a spectrum. And I see movement. India adding a third gender to their census. In Canada, there's a group that's working on coming up with a good way to be able to capture LGBTQI populations in their data collections. So there is some movement forward, and I think importantly around standard setting, that would be a resource then for all kinds of for researchers and others looking to study that spectrum.
Can I say something about that? Because I think it is also important if we are looking at collecting data and we are looking at a gender analysis, that for instance, when we talk about the LGBTIQ community, we are talking about a discrimination agenda, but sexual orientation does not define, I mean, it's not the same. It's having a specific sexual orientation with a gender or with a gender identity. So I think that when we translate this into data collection, and we need to start making also the difference of what it may be anti-discrimination and human rights and barriers to the access to the health services with data collection. And I can also say that in many of the countries where we are working, there is a huge backlash of using different political agendas to actually completely clash and go against the gender analysis and the gender equality agenda. So we have to also put be very conscious that we are talking about both a scientific process and a political process, and how do we navigate within. It's very important.
Well, I agree, and I think certainly on this issue, I think that's clearly at play. So it's interesting to watch. So let me turn now to some questions about some of the individual presentations. Let me start with Drs. Sober and Quimby. Here's the question that came from our listening audience. With the Caribbean study, did you assess, or the Barbados study, did you assess differences in exercise, diet, and obesity among women by stratifiers such as income and education?
So we didn't do that for the entire Caribbean, because the Caribbean study included all 31 countries defined within the Caribbean, but we did look at it in terms of some individual countries. And so, for example, in Barbados, in women, higher educational levels were associated with higher fruit and vegetable intake, more physical inactivity, and less diabetes. So persons who are lower educational level were definitely disadvantaged in terms of the behavioral risk factors and also the diabetes outcome.
Okay, thank you. And then for Ms. Aguirre, the question is, these data are very interesting and will be useful for understanding the current differences in COVID mortality, so in the coronavirus mortality. Have you considered how these findings might be used for this response?
Well, no, because we don't have all the findings yet, but I think that definitely we're actually working with the different UN agencies on how do we look at gender and COVID, and there has been also, like Rosemary's paper and others in the Lancet of watching and monitoring this, because the responses will have to be different. The problem with emergency is that we are being overrun by the immediate response on the basics capacity of the health sector, but we are looking at what can it be behind. And as I put also on the text, I mean, there may be reasons in terms of the link with the respiratory diseases. There may be links in terms of whether these people come at the later stage because of living arrangements, living alone or not having carers around, but definitely should be integrated into the response. But we haven't started, we don't know yet how to tackle it.
Okay.
I can just add a few words for this.
Yes, thank you, Ivo.
And I'm working specifically more with NCDs than with gender. We do see that the highest mortality from COVID is among people with NCDs, and especially among older, frail people. So I think there is a very strong link between comorbidities and COVID mortality. And we see that 75% of deaths are among them, especially in the age group 85, 80 plus. I have posted a link to a dashboard prepared by WHO Europe, where you can see some of the links with age. And I think there will be, in about less than a week, there will be a fact sheet coming out specifically about NCDs, as comorbidities, and COVID mortality.
Great, thank you, Dr. Rakovac. If you could, if you have the website or the link to the dashboard, you could put it into the chat box so that people can. So that'd be helpful. And then let me finally turn to Dr. Peters. The question from the participants is around transgender populations, and are they included in these kinds of studies, the ones that where you presented results?
Great question. Well, we would love to, but unfortunately, studies among transgender populations are still very small. So we are not, at present, we haven't been able to look at transgender population, but that's certainly something I think, yeah, we would love to in the future, because it would, of course, give a different perspective on whether some of the differences we find are due to biological factors or more due to behavioral factors. So yeah, great question, but not we haven't been able to do it so far.
Okay, great, thank you. Let me just turn to Oxford and Emma. Should we move to closing the discussion, or should we have another round of questions?
Hi, I think we'll probably have to wrap up because we're almost at 2:30. So thanks so much to everyone for joining. Albert, did you want to say a last word before I cut you off?
No, just actually compliments to all the panelists for, I thought we're really like a coherent set of presentations, which took us, you know, from the theoretical to the actual what's happening in the field. So very, very much appreciated. Thank you.
Yes, completely agree. I mean, what a fascinating webinar on what is a really, really important topic. So huge thanks to everyone who's joined. A special thanks to our moderator, Albert from the Equal Measures 2030, and all of our speakers who've joined us today, to Natasha and Kim and Isabel and her colleagues Eva and Brett, and my own colleague, Sanne. Really, really engaging presentations. Thank you. And equally, thank you to everyone who's joined, and thanks so much for getting involved in the discussions. I'm really sorry we didn't have a time to get to all of your questions, but we'll be capturing all of the discussions, including the questions we didn't get to, the resources that have been shared in the chat box, the suggestions and so on. And we'll be sharing those outputs with you via email, so do stay tuned for emails. As Albert mentioned, we'll also be sharing a link to the recording of this webinar, so look out for that. And finally, just to mention that this is the 4th webinar we've held as the Community on Women and NCDs, and there are recordings available of the previous 3, which have been equally engaging. So if you'd like to watch any of those, do check out the relevant page on the George's website and also on the WHO's Knowledge Action Portal. Again, we'll send all the details and the links around in email to follow this webinar. Thanks very much again to you all, and hope to see you on another webinar again soon. Thank you.
Thank you.